When I was 9, I used to work for a grocery store in Central Falls. I'd walk for hours, distributing pamphlets door to door. With hand-me-down oversized sneakers, I walked and jogged for miles to deliver those papers. Now, I wake up every morning, ritualistically tying the laces on the same size sneakers that I've finally grown into, and I run. I run on the still crumbling streets that I once covered as a boy, passing across city bridges and lines, into the well-paved paths of neighboring communities. There's a moment, as you're running, when your heart begins to pace so quickly that you wonder whether the next beat might be its last. Do you stop? Do you quit? Do you keep going? That's the breaking point, and every morning I cross it. I push beyond it. With each stride, I dream and wonder what progress might look like for my daughter and the many generations that will follow. My name is Luis Daniel Muñoz. I'm a medical doctor, organizer, husband, and father, and I am running for governor of Rhode Island. I was born to Puerto Rican parents, and as one of 5 children raised by a single mother, the path was not paved for someone like me to run for this office. But things haven't changed for working families who are still struggling to survive. I'm running because we can't afford to wait another day for political courage. I'm running because it's time to declare that a child's fate should not be based on a lottery system, a person's health should not be based on their zip code, and no parent should have to decide between feeding their children or paying their rent. What we need in Rhode Island is a commitment to environmental justice, an increase in affordable and low-income housing, a free and accessible community health system with fair and equitable health insurance options, and an education system that makes greater investments in our youth and their future. The power of the people has always been greater than the people in power. It's time to unite and to demand better. As a kid, I worked for change. As a doctor, I worked for hope. And as governor of Rhode Island, I'll work for progress.
Good evening. It is Tuesday evening, and welcome back here to Pump Up the Volume. It's been about a week since we last spoke. As you know, over the last 2 weeks, we've had amazing guests on. We had Senator Tiara Mack, as well as Harrison Tuttle from Black Lives Matter Political Action Committee, talking about repeal of the Law Enforcement Officer Bill of Rights. And some great testimony was provided about 24 hours ago on that. So please check out Twitter. Follow Senator Tiara Mack, and you'll see where that went. The next week, we also had Executive Director, or last week, that is, the Executive Director of Direct Action for Rights and Equality, Kia Bryant, and we were really focusing on the challenges with how state chooses to work with community organizations, and frankly, the exploitation that takes place in utilizing community labor, not compensating it, and ultimately not even learning from it, which is problematic when you think about creating sustainable programmatic change. There is a path forward, there's a solution, but hopefully if you take a listen to those 2 weeks, you'll better understand how these challenges are perceived through the lens of people that are living it and working with communities that are living it. And again, continue to hopefully inspire you all to do something about it. This week, we have a special guest as well. We have Dr. Katrina Byrd. Again, I want to just lift up that, while physicians are all doing amazing work, helping lives, reducing suffering, saving lives, not all physicians take time out of their practice or their academic time or their research time and really just take it away and apply it to doing community work that's uncompensated and at times unrecognized. So I just want to lift up Dr. Byrd. Dr. Byrd is coming out of Brown University, an expert in infectious disease, pediatrics and medicine, I believe, is a combined specialty. And Dr. Byrd, please correct me if I'm wrong. I'll hand it off to you, but I do want to make sure that I at least point out the highlights. And over the last 4 weeks, in addition to all the amazing work that Dr. Byrd does as a physician, as a clinician, and really, of course, advocating on issues of diversity, health equity, really was leading the clinical operations effort around bringing clinicians of color into the mass vaccination sites for the BIPOC mass vaccination weekends that we were talking about over the last few shows. So thank you so much for joining us, Dr. Byrd. And before I hand all of this over to you and just give you a space to share your knowledge, and we'd love to hear more about your background from you as well. I do want to just again thank my fellow co-host, Pat Ford, founder of the Coalition Radio Network and co-founder of the Libertarian Party in the state of Rhode Island, and the friend that has heated debates over beer guy. So thanks a lot, Pat, for being with us again. And also my friend Scott Rotunda from WBOB 990. Also, just the treasurer on the campaign, not just, but the treasurer on the campaign, and someone who's been involved in local and statewide politics. Independent of the media reporting, because Scott also covers national news, but at least in terms of getting his hands into campaigns and doing the work, has been involved in Rhode Island politics for a long time. So it's great to have my fellow co-host here. The layout will continue to be that when we have special guests, we want the time to be the special guest time, but we will all get 1 to 2 questions, likely one, given the time that we have. And just to provide the order, Scott, you can have the first question. Pat, you can have the second. And then if there's space, I'll ask a third. Otherwise, Dr. Byrd, thank you again for joining us. And the floor is yours. We'd love to learn more about your background and also gain some insights into your knowledge around COVID-19 and the current situation.
Thank you for having me. My name is Katrina Byrd. So in terms of my clinical background, well, I'm originally from Detroit, Michigan, and I did my internal medicine and pediatrics residency, which is specialized training after medical school at the Medical College of Wisconsin, which is in Milwaukee. And after training there, I moved here to Providence in 2018, where I completed my adult infectious disease fellowship and I'm board certified in adult infectious diseases. And because I love infectious diseases so much, I decided to do a pediatric infectious disease training or fellowship. So that's what I'm currently doing now. And briefly, my journey in regards to COVID-19, this pandemic really popped off probably late February here in Rhode Island, where we had our first case of COVID-19 after a teacher traveled from Italy. Well, the teacher was from here, but vacationed in Italy and came back, and unfortunately was one of our first very, very sick cases of COVID-19. So just like experiencing the pandemic in the hospital was kind of scary. One thing I was noticing is that it went from a disease that was kind of affecting people from all walks of life to really disproportionately affecting people of color, Hispanic, Black populations here in Rhode Island. So I really noticed that and wanted to do something about it. And that ultimately led to really educating myself first on the COVID-19 vaccine because I didn't trust it. I'm not gonna lie. Like I did not trust the vaccine. So I really do understand how some people can be hesitant because I was hesitant myself. But once I really looked at the primary data, it's really good. I do trust it. And from there, I started advocating, to different people in my personal circle, and then I've expanded from there. So I am well versed in COVID-19, in the vaccines. So I'm going to just step down and allow you guys to ask me questions because I'm here to kind of talk about it.
All right. Well, I guess I'll lead off. First off, Dr. Byrd, thank you so much for taking time to come here and chat with us tonight. Really glad to have you. My question is this: as a medical professional, how do you civilly explain to people the dangers that we still face with COVID, especially in the face of you have people like Tucker Carlson saying, "Oh, they downplay the severity of COVID," even suggesting that young people, college age, don't need the vaccine because they'll get over it anyway. I've got to imagine it's very frustrating to try to tell people how dangerous this disease still is when again in this day and age people just listen to talking heads in the media as opposed to medical professionals. So how do you bridge that gap with lay people?
So I understand that sentiment. I don't agree with it, but I understand it. So here in America, we have over 300,000 people, but COVID-19 has affected over 20,000, and that's a very, very conservative. It's significantly higher than that people. So it's not possible for everybody to personally be affected or personally see someone with COVID-19. But I'm here to tell you, I've literally seen people die from this disease. I've seen them on ventilators, and I've seen 20-year-olds, young, relatively healthy people get very sick. I've also seen children. No one wants their 2-day-old, coming down with COVID-19. I've seen that. I've seen young children. I've seen children like I said, as young as 2-day old, as well as adults who are well in their 90s. This disease, we hope that if you were to become infected, that it would just be like a cold and it kind of goes away quickly. But for many Americans, this is not the case. A lot of times people are having long-term side effects like prolonged difficulty breathing, prolonged loss of the sense to smell and taste. And so really, I ask people to think beyond themselves, to really not only care about themselves, but to care about their fellow man. And I think sometimes that's really difficult to do because it's easy to think about me, I, how is this affecting me? But really, I ask people to have compassion, compassion for other people and really realize that this is like we all need to protect ourselves and we all need to work together in order to control this pandemic.
Exactly. And my brother works in the medical field as well, and he's seen people pass away from this. So yeah, the people that say it's a hoax or that it's a pandemic or what have you, I mean, shame on them. And to your point, people that are self-centered and will look at it like me, I. Actually, just got my second vaccine today. I mean, from soup to nuts, it was maybe a 20-minute process, and 15 of that was after the shot, just waiting so that I could go. So it's not like the sacrifice is something awfully big that we're asking of people.
Agreed.
Doctor, let me jump in for a second.
Pat,
oh, I'm sorry.
yeah, okay.
The term long hauler is associated with folks who continue to suffer from the disease, as well as folks who have the I'll just say the primary way the disease exhibits itself has been mitigated largely, but they consider to suffer issues afterwards. What have you seen in terms of Rhode Island statistics? And I don't know if they're compiling these or not, but how many folks are suffering long-term consequences from this, and what are you seeing in terms of consequences?
So I don't know if anyone is actually collecting that data because it can be really tricky. Even if you have mild disease, you may not have come in contact with the healthcare system to actually know that, hey, I still have difficulty smelling or difficulty tasting. So I don't know the actual numbers, but I constantly get calls from pediatricians and primary care physicians saying, look, my patient had COVID 6 months ago and he's still suffering for this. So and then so for this disease, a lot of things have been published in the scientific literature so that we all over the world can learn from each other. And when I'm talking about the long-term side effects like difficulty breathing, blood clots as a complication, heart problems, difficulty with smell and taste, these are things that not only have been seen in America, but all over the world.
And I mean, is anyone at any level compiling these statistics or doing research into this? Because this seems to be an issue overlooked largely by the media, with the exception of maybe the New York Times and the Washington Post. And it strikes me as a compelling story that should be part of the calculations in how one responds to this.
Yeah, I'm 100% sure people are looking at this data. I'm just not intimately aware of who exactly is collecting the data.
Hmm.
So we'll find out when they publish the paper, I guess. But I'm sure it's being studied because we already have like some of the major neurology papers. What to your point, you do bring up a good point. Like, why isn't it making mainstream like news, like New York Times or CNN or MSNBC? That's actually a really good point.
Interesting. Doctor, I'll turn the ball over to you.
Yeah, I'm just there's just so many layers to this, and without a doubt, like I'd love for the audience to really understand something that you've mentioned. So I just want to lift that up again. That there are children who are being brought in by their parents that are being brought in with symptoms of not being able to smell and taste. And like it's happening, and that's not that they're necessarily having difficulty breathing, right? I mean that's that they're losing, they've lost a sense. And so the question becomes, what is the long-term impact of that? And maybe that's a longer discussion, but I just wanted to lift that up, because there
Yeah, I
continues
can
to be
talk a
this.
little bit.
Yeah. Okay.
Oh no, I
Yeah,
can
please.
talk a little bit more about pediatrics and COVID-19, which is a little bit tricky. So a lot of young children can be infected with COVID-19 and show no symptoms. We know this is happening because what we're seeing in the hospitals is this syndrome called MIS-C, or a multi-system inflammatory syndrome, where children have been infected with COVID-19 and had no symptoms, most of the time had no symptoms. And then 2 to 8 weeks later, they're coming into the hospital devastatingly sick, fever, low blood pressure, rash. Some of them have difficulty breathing, some of them don't. Their heart doesn't pump like it's supposed to. And children, although it's a relatively rare phenomenon, children have died from this, especially early in the pandemic when we didn't know that this was happening. So I know there are some adults that are like, look, I'm young, I'm healthy, if I get this virus, I'll be fine. But they really need to look at their children, look at their young ones, because they can infect their children, and initially the kids will have no symptoms. We can't predict which children will have this MIS-C. We can't predict at all. And so for if you're like thinking like, I'm not sure if I want to get vaccinated for myself, I would think I would look at your children and get vaccinated for them to protect them, because at this point, if you are a child less than 12 years old, you don't have access to the vaccine yet. Luckily, Pfizer has now received emergency use authorization to be used in children 12 to 15.
Yeah, thank you so much for sharing that, Dr. Byrd. So just to kind of take that and segue into kind of a political side of this, which to bridge the political side, I'm kind of going to bring it to the national level and then bring it back home to Rhode Island. We hear a lot of people who have concerns about, essentially waiving any restrictions around patent ownership, right? So that countries can start to manufacture the vaccine. And the concerns are, well, free market, this and that. But I think anyone in healthcare understands that most of these technologies and platforms are built with millions of dollars in NIH funding that starts in laboratories, makes its way to hospitals, and then gets to market. So these are publicly funded technologies that ultimately end up being owned by companies that, increase the prices of them to make their profits. And so that is the industry. That's another argument. But the reason I'm mentioning that is, so often we see a challenge, but the politics behind it is not necessarily understood by the public. And so people will react to something taking place And oftentimes there's this like weird situation of like economics versus life, and healthcare too often runs into that question, like profits or lives. And so as as you were talking about pediatrics, and as we're looking at infectious disease on the Equity Council, what was interesting early on, when I say early on, I mean as November, right? I mean, COVID time seems like forever, but November of 2020, there were discussions around what was considered an outbreak in a school. And it was really a play of words. If someone was infected in the community, went to school, and then infected someone else, it was not considered an outbreak that started at school, therefore it was not a school outbreak. And I'm getting to the kind of full circle here, which is thought experiment. Do you think if you went to the Department of Education in Rhode Island and said, I'd like to conduct a comprehensive study with parent consent to test 200 children consistently over the course of a month to try to look at the rate of asymptomatic infections to see whether we're missing something, to see, especially as the variant from India comes in, whether we should be concerned? What would the politics around that look like based on your experience and research?
That would be challenging. But before we even get to the politics, to do research on children are considered a vulnerable population, and then humans, and when you do research on people, because of the atrocities that happened with Tuskegee and other experimentation, uh, there is a very lengthy institutional review board or very lengthy overview of the study. So let's say you were able to get approval. I think that is going to be tricky because we're dealing with children, and you have to think, how would you obtain the actual testing? Are you going to stick something in their nose? Are you going to do a mouth swab? I think that it would be really uncomfortable, and I don't think it would be very difficult to gain support. I see where the science is, valuable, but because it's children, I think the support will be difficult to obtain.
It's interesting. They put Binax now into schools, right? So they were doing some testing, but the question becomes, was it sufficient to really
Well,
provide a,
yeah, so because that's if I'm not mistaken, that's a rapid test. And so that
right,
one
right.
isn't as accurate as the PCR test, the one where you have to stick up the nose. Um, so that's one. The other thing is the Rhode Island Department of Health is doing work in regards to looking at the variants. So there's some background surveillance that is happening for if you test positive, what happens to your sample? Well, they want to know what type of variants are in the community. So that is testing, and that work is being done on positive samples.
In Australia, they're testing the sewage to try to track down epicenters of infection. I mean, do you think that we have the capacity to do that in Rhode Island?
I think it's possible, but then where I can't accurately answer that question because I am not intimately familiar with the sewage system. Now, if it was very clear that our sewage runs one way and you can backtrack where it came from, but if it's more complex and sewage comes from all different places and you can't track the source, that might be a little bit difficult.
In Pawtucket, I think it mostly backs back up into people's houses most of the time. But no, jokes aside, um, yeah. So where do we go from here? We're moving forward, and it's great to hear that 12 to 15-year-olds can receive the Pfizer vaccine. But my daughter's 3. I'm still very concerned, especially when I
Yeah.
hear about this. When I read more on the variant from India, I think everyone in the scientific community, just to put it out there, I think we always want enough evidence to say we are seeing a difference in mortality that's statistically significant. But my concern is that even if we saw signs of a difference in mortality rates from one variant to the other, we would wait, because the science would call us to wait for the sample size, for the amount of people that to die from a variant to increase. So I always err on the side of assuming if a variant like the one we're seeing in India is that much more transmissible, is it possible for it to be even slightly deadlier? And if so, what does my 3-year-old have to be, what do I have to be concerned about for my 3-year-old daughter? So like, where do you think we're
Yes.
going, especially with people younger than 12?
Yeah, so definitely. So number one, I know the person who's doing the work in regards to monitoring the surveillance. So this is already happening in the background of the DOH. So that's number one in terms of knowing what variants are prevalent in Rhode Island. So that's number one. Well, what I would say to a parent who's really worried about variants and really worried about infection in their child, get vaccinated. That's the number one way you're going, in addition to continuing to mask, social distance, and really following CDC guidelines. That's how you're going to protect your little one who isn't able to get vaccinated. The other piece is we need to get that 12 to 15-year-old age group vaccinated. When you think about transmissibility, or how well can children transmit this virus, the little kids like your 3-year-old, they don't transmit well. Most likely your daughter will, or 3, 6-year-old, the young kids, they're gonna most likely get infected from an adult or an older teen. It's the middle school age and high schoolers who we should worry more about in terms of transmitting virus. Why? They're bigger, they have bigger lungs, they're stronger, so they're really going to be kind of acting more like an adult. So the next thing is to get the children in those age groups vaccinated. The other piece that's important is making sure we all have access to the vaccines. And I think that's where that is where the work in progress is. It's multifaceted. One, we need to make sure everyone feels comfortable in that is, they know the science, they know that it's safe, and answer any questions that people have about the vaccine. Two, it's the access piece. And I think that is the hardest part, because if you go, people still think they need insurance to get vaccinated. People still are worried about their immigration status. People are still worried about needing an appointment. You don't need an appointment. You don't need, you don't need to have money. These vaccines are free. And you don't have to have insurance. No one cares about your immigration status. We're just trying to get everyone vaccinated. And I'm not just talking about Rhode Island. If you look at the CDC website, it says this. So the issue is, how do we translate this message and get it into multiple languages, get it to people who may not have TV, who may not have radio, get it out there so that people feel comfortable coming out to get vaccinated. That is the part that we're really struggling with, because when you look at like racial ethnic background, let's go nationwide, white, Caucasian or white are vaccinated. There are no disparities in that group. When you look at Asian Americans, there are no disparities in that group, meaning that, they represent this amount of the population and this amount of the population has been vaccinated. But when you look at Hispanics and Black African Americans, they're under vaccinated nationwide and they're under vaccinated in Rhode Island. So how do we reach those communities? That's the challenge that we face.
So last question, just to respect the time that you've provided us, and I know how busy you are. Even with the CDC, there seems to be inconsistencies in the framing of information, and that framing at times encapsulates like a limited understanding of cultures, like the nuance of what a word means for one culture versus another. In one of our first weekends with BIPOC Mass Facts, we had experts from the state talk to us about a focus group that somehow led them to believe that using words like free was not clear enough, that they had to use no cost. And so then the question from my perspective became, who was a part of that focus group? Were there Blacks, Latinos, Asians, Indigenous community members, or was it primarily, Caucasian individuals? Never got in, we never went into that. But how important is it for communities to lead and provide some level of oversight around how the messaging and communications are framed, not only around vaccine registration and safety today, but frankly around the probably booster shots we're going to need to take 12 months from now? What does that look like?
I think that it is very important that communities are involved in the framing of messages to their community. But I want to make one thing clear. It is not the responsibility of the community to do the messaging. It is the responsibility of the Department of Health and the government, because they have the money, they have the resources. So it is their responsibility to get the message out to everyone with partnership, partner with communities and not put the burden on, partner with community leaders, but don't put the burden on community leaders. That's what I'm trying to say. Unless they're going to get support by giving money, support by giving resources, including staff, that is a way that you can support community leaders. So I think that it's important also, and this may seem like backtracking, that we should give each other grace, because this is no one anticipates this ever happening, and there are going to be mistakes everywhere. But as long as we're doing our due diligence to learn from those mistakes and work together, I think that's imperative in order to come up out of this pandemic.
Awesome. Thank you so much, Dr. Byrd. And I know that you do some TikTok videos and stuff, I think, right? So do you want to give
I
everyone
do
your
IG
TikTok?
reels. Yeah,
IG
so
reel.
I
Okay,
do
okay.
IG reels. So it's DR underscore KBYRD. So it's DR underscore K Byrd. That's my IG and Twitter handle. And or if you get confused, you're like, oh my goodness, I can't. My first name, like KatrinaByrd.com. You can just go to my website and follow, find my social media there.
Awesome. Awesome. And some of your videos are really talking about everything we talked about today, right? Like COVID-19, vaccine safety, providing guidance. All right. Awesome.
Yes.
So hopefully everyone can check out KatrinaByrd.com or DR underscore KBYRD on Twitter and Instagram. Thank you so much, Dr. Byrd. And again, I just want to lift up that, Dr. Byrd is going above and beyond the scope of clinical work, beyond the scope of just research, and really doing the community work that's hard and really that's uncompensated. I just want to put that out there because it's not right, but it is, amazing to see that even when resources are not being given to community organizations and leaders, we have individuals like Dr. Byrd who, again, are going above beyond, risking the limited time they have as clinicians to support the larger mission here, which is to reduce the significant inequities that still exist within our systems, including healthcare. So thank you, Dr. Byrd. Thank you, Pat. Thank you, Scott, so much for today. I know the last few weeks have been reducing the amount that we're all talking, but frankly, I think this is all building up into what we've all envisioned this show to be, which is really a platform, a medium for individuals like Dr. Byrd to come on and to present insights into a challenge that the community may not be aware of, but now the community can have an active role in figuring out a solution. So hopefully everybody feels empowered about that. Thanks again, everyone. Dr. Byrd, thank you again. Hope you all have a great evening, and we'll see you next week here on Pump Up the Volume. All right. Have a blessed night.